syndrome with reversal of flow. If you look at the published data, 92% of these are detected in the first trimester. It looks exactly the same as it does in the second trimester of pregnancy. You look at this baby, in the published data, 100% of these are detected in the first trimester of pregnancy. And this is a baby, when you look at the right ventricle, it has not formed. The same baby seen at 30 weeks of gestation, you see that there are coronary arterial collaterals. And this becomes extremely difficult to pick these up in the first trimester. So while we can make very accurate diagnoses in the first trimester, we are limited in prognosticating because you cannot tell at 12 weeks whether coronary artery collaterals are present or whether they are going to develop. When we look at other conditions, common arterial trunk, this is a baby with a common arterial trunk here. We see arising from the right cardiac ventricle, and then in this here, we see a common arterial trunk arising centrally. These are very, very detectable abnormalities. Over 70% of these are detected in the first trimester of pregnancy. And 100% of these are detected in the first trimester. So this is a baby where you look at the branch pulmonary arteries. When you look at the branch pulmonary arteries, you see that there's bidirectional flow forward and reverse. It's an unmistakable diagnosis and very easy to pick. I see far more examples of absent pulmonary valve syndrome in the first trimester than I do later in pregnancy. This is a baby who I saw recently, descending aorta, left ventricle, and then you can see the aorta is sitting astride like a trouser leg, so it looks like the trilogy of Fallot. But this is the aorta coming out of both the left and the right ventricle. When I sweep up to the right ventricular outward tract, I see this vessel here, which is reversal of flow through the pulmonary artery. So it's going this direction and it's going this direction. So this is a baby with absent pulmonary valve syndrome at 13 weeks of gestation. This is the SEC, this is the aorta, and this is bidirectional flow across the pulmonary artery. A very important diagnosis to make, and something that we can make in 100% of cases. ABSDs in one series 90% detected, in another series 72%. And here you can see an atrioventricular receptor defect, a very detectable element of the first trimester of pregnancy. When you look at this fourth chamber, you see there's a missing in the center of the heart. It's very obvious. And if you do not see it on 2D, you will appreciate this when you look at the color. You have a normal 3-vessel tracheal view, looks good. When you look at the fourth chamber, you see regurgitation. The PREP is set at 25, you got inflow is red, but then you have a central jet regurgitation. Baby has got central tricuspid valve regurgitation or common AV valve. This tells you why it's so important to look at color Doppler, and this was picked up by using color Doppler technology. You can pick up even more complex abnormalities with parallel great vessels, and these complex abnormalities are picked up in 100% of cases in the first trimester of pregnancy. This is also an abnormality that we are seeing at 10 weeks because we do NIPT at 10 weeks, and we are seeing these when we look at the fourth chamber. We see this tricuspid valve regurgitation, and when we're looking at the 3-vessel tracheal view, we're seeing that it turns red and blue. It's forward and reverse, like this, during systolate and diastole on both the great arteries. If you do a 3-vessel tracheal view in every single baby at 12 weeks of gestation, it's an impossible diagnosis to miss, and a very important diagnosis. This is a patient pre-NIPT at 10 weeks of gestation, and you see that there's an increased nuchal translucency. And when you look at the flow through this is the trachea, so it's the transverse aortic arch, this is the pulmonary artery and the duct, you see the bidirectional equal volume of flow. This is not an obstructed heart lesion. This is a baby with polyvalvular dysplasia. It's got tricuspid regurgitation, mitral regurgitation, pulmonary artery regurgitation, and aortic regurgitation. It looks like when you first see them that they have tachycardia, but that's all it is. So we move on to the abnormalities that you sometimes see. These are more difficult. I accept that. And I've spoken already about transposition of the great arteries. So we reported for the first time transposition of the great arteries in the first trimester in 2019. So normally the pulmonary artery comes out like this, goes off the branch, but this baby comes out like a boomerang. And when you sweep to a 5-chamber, you can see both arteries come out in parallel. This patient is 13 weeks of gestation. The chances of a genetic abnormality are very low in TGA. In the reported data, less than 4% of babies with TGA. So we don't necessarily do a CBS. We wait and do an amniocentesis, but we do offer genetic testing in TGA because we never know 100% if it's isolated. In this baby, you will see this is a difficult diagnosis at any stage in pregnancy, with the detection rates about 1/3 in the first trimester. When you look at this baby, you recognize that the 4-chamber view of heart, that the left cardiac ventricle is smaller when compared to the right. So this chamber is small, and this chamber is larger. This is the descending aorta, that's the left atrium. When you look at the 3-vessel tracheal view, this is the trachea, SVC, and that's the transverse aortic arch. And you see that the transverse aortic arch is really narrow. So it is detectable in the first trimester of pregnancy. This is a baby with tetralogy of Fallot. And if we look at this case on the 5-chamber view, this interventricular septum, you see there's a vessel that arises across the right and the left ventricle. And when you look at the color Doppler, you can see turbulent flow of a big dilated vessel arising out of the heart. So tetralogy of Fallot is a very detectable abnormality, and the recent published data shows so. And I will be talking about this in more detail in a second. Cardiac axis deviation, the case today with Dr. Ryan at 2U Hospital, we saw that the heart is lying on its side, it's tilted on its side. We notice that the aorta is to the left of the spine, which we're sitting directly above the spine. And when we look at the 5-chamber view, we can see the overriding of the aorta. We then look at the 3-vessel tracheal view, and we do not see a normal 3-vessel. We see this Y configuration. And a Y configuration is a very useful marker of TGA. So that's important in looking at the configuration on the 3-vessel tracheal view. These are all babies with tetralogy of Fallot, all picked up because the 3-vessel tracheal view was abnormal in all of these babies. So instantly, when you do a 4-chamber and a 3-vessel tracheal view, you will appreciate the 3-vessel tracheal view is abnormal. Epstein's anomaly, again, is very detectable. It's strongly associated with trisomy 21 in the first trimester of pregnancy. You may see the big dilated right atrium. Sometimes the right atrium in the first trimester may be normal, and then the second trimester it may be very large. But this is the first trimester, this is the left atrium, and the right atrium is large. And the regurgitant jet lies deep inside the right ventricle. This is the baby at 13 weeks. It is easier to see the regurgitant jet than it is to see the septal leaflets of the tricuspid valve. If I want to see the displacement of the septal leaflet, I need to go to a transvaginal 12 megahertz, and then I can see it, but it can be difficult. This is a baby, when you look at the tricuspid valve, it's normally positioned, but it's like a skipping rope. You can see it going back and forth like a skipping rope. And when you look at the color Doppler, you see a jet comes up, hits the roof, and then comes back down like a mushroom cloud. This is a baby with tricuspid valve dysplasia, and remember, trisomy 13 and trisomy 18 are commonly associated with this. I mentioned about arch abnormalities, so you go to work, you do a 4-chamber, you split, and then when you look with color Doppler examination, you look to see whether there's a normal 3-vessel, but you see that these vessels are coming out parallel to each other. It can be so difficult when you look with color. I see that's abnormal, but if you're very junior training, you may think, well, that's okay. With color Doppler, you won't, but if you go to power Doppler, it becomes much more obvious. This is using graphics flow with a very magnified image of 13 weeks of gestation, and you can see in the middle is your trachea, this is your SVC, this is your aorta, and this is your arterial duct. So important to make this diagnosis in the first trimester, because you are going to offer invasive genetic testing by CBS and look for a 22q microdeletion. So these are important abnormalities. And then there's the never group. This is a group which are, in medicine, I say never, because you will disprove it at the time. But This is a baby who's got a muscular ventricular septal defect. So I think in 2026 that muscular ventricular septal defects are detectable abnormalities. So this is a baby who's got a muscular VSD, but otherwise the heart looks completely normal. A normal left ventricular temporal tract, a normal pulmonary artery that crosses over, and then a normal three-vessel tracheal view. So this is a baby with a completely normal heart. This is a baby at 11 weeks of gestation who is in increased nuchal translucency, who has an absent nasal bone. And when you look at the four-chamber view of heart, you can see there's a perimembranous VSD going from the left to right. So I think you can pick up muscular VSDs, I think you can pick up perimembranous VSDs, and I think we're in the new world of high-frequency imaging where you can see a lot of these problems. I mentioned in terms of complex abnormalities that you can pick up. So this is a baby, when you look at the descending aorta, the left ventricle is absent, there's a normal right ventricle, and you sweep up, you see the pulmonary artery, right pulmonary artery, the aorta, and the SVC. But sitting beside the pulmonary artery, you have this red vessel, and you follow up to the neck, it goes across to the left brachiocephalic vein, and then comes down to drain into the SVC. And this is a baby with supracardiac, total anomalous pulmonary venous return. The baby has a hyperplastic left heart and TAPVR. 50% of babies with TAPVR have the supracardiac type. In the past, we said you can never make this diagnosis in the first trimester. In the past, we said you can never make a diagnosis of a VSD. But I do believe with improving resolution, it is possible. So let me ask a question. What difference does this talk make to you when you go to work tomorrow morning? Well, the first thing I will say to you is that for every single examination that you do, take a single image, split it in two, and show a four-chamber view of heart, and then showing a three-vessel tracheal view in color for every examination you do. If you do that, you will reassure you that you are looking at normal cardiac anatomy. This will be the step to picking up what is not normal, number one. Number two, for every baby that you're examining, you should consider using Doppler, color Doppler, and I would say use power, would be my preference, and set your ear at 25 to 35 centimeters. Understand that there are three groups of abnormalities: those that you will sometimes see, those that you will never see, and those that you will always see. And you as an obstetrician need to be aware of those groups. And remember that abnormalities look no different at 12 to 30 weeks when compared to 20 weeks. It's just everything's a lot smaller and you have to work harder. And if you are serious about first trimester diagnosis, then I would recommend you consider routine vaginal evaluation in all pregnancies. Thank you very much for your attention.
We will continue the next session chúng ta sẽ bắt đầu với cái bài là tứ kiếm pha-lôn, dấu hiệu chẩn đoán và mở rộng của giáo sư Simon. Please, Professor Simon, we continue.
Okay, so